Dr. Anne Koehler, Deputy Director and Senior Medical Consultant with the Communicable Disease Control Branch in SA Health. So Anne is a clinical microbiologist who has worked in the Communicable Disease Control Branch in SA Health since 2004. She is also an Associate Professor in the School of Population Health at the University of Adelaide. Anne has strong interest in infection control and immunisation. She has represented CDNA on the National Immunisation Committee and has been a member of the Australian Technical Advisory Group on Immunisation. Anne is here today to talk to us about public health and clinical management of influenza. So I will hand over to Anne. Thank you.
Thanks for the opportunity to speak about the influenza virus. I'm going to talk just mainly about the virology, the clinical management and public health management for influenza. So influenza viruses belong to this family of viruses called Orthomyxoviridae. It's really the main virus in there of interest to humans. There's some others that infect animals, but this is really the one that we know most about. It's an envelope virus, which is great because it means it's very susceptible to soap and water and alcohol hand gels. It's an RNA virus, which is not great because it means that it's very unstable genetically and it's constantly changing, which is why we have to keep vaccines constantly changing at present. And the thing I find most interesting about it is it's actually a zoonosis. Influenza virus normal host is water birds in Southeast Asia, especially southern China. That's really where almost all of the influenza strains originate. And they hop species into humans eventually, sometimes via pigs, sometimes directly as in avian influenza, and adapt to humans, and then they just become a circulating human virus. They're unique amongst the viruses in their ability to, in their antigenic variability, so that they constantly mutate, as you realise. There's other viruses that do that too, so HIV is one of the viruses that does change quite a bit. They've got a very strong seasonal pattern, which we do see with some other viruses, but often it's driven by influenza. And although in temperate areas influenza is predominantly a winter virus, a winter infection, in tropical areas it does tend to be more year-round. And it's also unique amongst its impact in the general population. There's not many other diseases that kill so many people worldwide every year. There's a number of subtypes of influenza, and influenza A is the first one in the list. So it's classified on the basis of its hemagglutinin and its neuraminidase molecules. So hemagglutinin molecules are these, in this diagram, spikes on the outside of the virus. So this is the whole viral particle. And hemagglutinin is very important in attachment of a virus particle to your cell, basically, to the mammalian cell, or the birds, or whatever. So if we had something that could knock out hemagglutinin, the virus wouldn't be able to bind to our cells and it wouldn't be able to infect us. But we don't have any of those drugs yet. The neuraminidase molecules, which are depicted in this red colour here, are involved in the release of the virus from the cell. So the virus particle gets into your respiratory epithelial cell and it multiplies in there, and the neuraminidase molecule is important in it getting out of the cell and going on to infect other cells and then ultimately to infect other creatures. So we do have drugs that effectively target neuraminidase, and you're very familiar with the neuraminidase inhibitors, which I will talk about a little bit later. So if you get sick and you're taking a neuraminidase inhibitor, you've still got lots of influenza virus probably replicating in your throat, but it can't get out, so you're not very infectious or not so infectious to other people. And it also, if you start it early, it means that the virus can't spread to more and more cells in your body and make you sicker. So that's why we have to start those drugs very early. The other molecule of great interest to us is the M2 ion channel. It's a little channel through the membrane of the virus or through the surface of the virus, and it's really important in stabilising the virus particles, particularly when they're getting out of cells. And it's a target for vaccine development. It doesn't change as much as the neuraminidase and the hemagglutinin, and people look at it as a target for vaccines, and that's where, when you hear people talking about a universal flu vaccine, that's one of the things that they're trying to develop a vaccine against. Unfortunately, it's not as antigenic as the hemagglutinin and the neuraminidase, and so it's harder to develop a vaccine that can bind to any antibodies that it might produce. You don't get such a strong protective effect. So they haven't really worked so far. And we do have a drug that targets the M2 ion channel, which I'll talk about later. So we classify the viruses on the basis of the influenza A virus on the basis of the hemagglutinin and the neuraminidase. So you get hemagglutinin type 1, neuraminidase type 1, type 3 N2, H5N1, and there's I've probably got my numbers mixed up. I think there's 18 hemagglutinin types and 11 neuraminidase, but I might have those numbers around the wrong way. Influenza B viruses, they are described by lineages. So you'll be familiar with things like Victoria, Yamagata, Brisbane, and so on. Type A viruses are the ones that cause pandemics. So far we haven't had pandemics caused by any of the other subtypes of flu virus, but type B viruses also cause a lot of human disease. In the last few years, the type B viruses have been particularly severe in children, more so than in adults, and that does change from year to year. Type C virus we don't test for very much, but it causes mild respiratory infections in humans. It doesn't cause pandemics. And there is a type D virus which so far hasn't been found in humans. It infects cattle and some other animals. Just talking a bit about the local epidemiology. This was Australian numbers for last year, up to the 6th of October. Last year, remember, we had a flu season that started quite early, and it went on for a long, long time, didn't it? We had over 304,000 cases in Australia, whereas in 2017, which was our previous bad year, we had fewer cases, but it was a more concentrated peak of cases. So it's hard to decide whether you get more worn out by that really busy, short, sharp peak, or whether you get more worn out by seeing flu patients day in, day out for 9 months of the year. But every flu season's different, as you can see, but most of them do have a peak around September, and most of them do start around June, July. Last year was different, who knows what this year will be. For South Australia, just showing you our data for the last few years. So back to 2015, which was a big flu season. 2017 was our biggest, and 2019 was also very big. And you can see that in between those big years, we have had fairly low flu seasons. So I am hoping very much that this year's going to be one of those, because we have other things that are going to be taking our attention. And it would also be nice if we don't have too much co-circulation of viruses, but we don't know. In South Australia, we had, so last year, 26,264 cases, and almost all of them were flu A, so 22,000 flu A's. It was the big one. Flu B, about 4,000. And only 107 deaths were notified to us. We try very hard to get death notifications. Doctors have to notify us about cases, but we do know that doctors were overwhelmed and we didn't get all of those medical notifications. So we also trawl through the register of births, deaths and marriages and try and find where flu has been recorded as a cause of death. So they were all flu A, but we do expect deaths from flu B too. There was only one young person, it was a 15-year-old, who was reportedly otherwise healthy, but in fact she wasn't otherwise healthy. And, she was very, very underweight and had some other issues, not medical issues, but she was not a particularly healthy child. There's 7 aged up to 69 and 99 over 70, so 92% of the deaths were in older people, which is kind of what we expect. The clinical severity, though, was relatively low at 0.4%, and it was a year that we had quite a good vaccine match, so that may have helped to keep the mortality rate low. Clinical management, the first thing we like to have is testing. I know that there's a lot of debate about why do you bother to test people when you're pretty sure they're going to have flu. But I'm a microbiologist and I think everyone should be tested, but that's just me. Serology tests really are old technology, and as they are slow to get results. You don't have a good measurable antibody response for about 2 weeks after you get infected, by which time it's all over pretty much for most people. It can't distinguish whether the antibodies are from vaccination or from infection. It's useful for research, for sure, and it has declining clinical value, and what we really want is not serology. Viral culture is no longer done routinely. When I was working at IMVS, we used to do viral culture for flu. No, almost nobody does that outside of reference laboratories now. So it's not a routine diagnostic test. Back to culture. So we do cultures when we did in medium, a viral culture medium that had cells in it that were particularly susceptible to flu viruses. And of course, when viral culture is done for vaccine production, it's still mostly done in eggs. And eggs produce a good yield of virus, and which stands to reason since it's basically an avian infection anyway from the start. But the test, of course, that I want, and where I didn't have a slide, is nucleic acid testing, so the throat swab, which gives us a rapid result, can differentiate the type. In South Australia, we only get an A or a B, but reference laboratories will subtype them further than that. So we do get some subtyping for our South Australian flu strains, but not as much as we'd like. Clinical management is, for most people, supportive care. But this is one thing that I really want to emphasise. Prompt commencement of neuraminidase inhibitors is recommended for people who have confirmed or suspected flu, who need hospitalisation. So anyone with severe flu, really, we would like them started on a neuraminidase inhibitor. Not an antimicrobial antibiotic, not an antibacterial drug, which is unfortunately what we hear all the time. Oh, the doctor said I had flu, so he gave me some antibiotics. But when you've got flu, the treatment is a specific flu drug, and we have got them now. And if you treat the flu, you probably can avert most of those secondary bacterial infections. So people who are at risk of complications are also all recommended to get neuraminidase inhibitors, and these people are those who are under 5 years old, over 65, pregnant women. The Tamiflu and oseltamivir and Relenza are safe in pregnancy. Aboriginal and Torres Strait Islanders are at high risk. I doubt that very many get antiviral drugs. Immunosuppressed people, people who've got significant comorbidities, and especially respiratory and cardiac problems, and people who've got severe complicated or progressive disease, and these are your people who are going to end up in intensive care units where they will be certainly put on antiviral drugs. The antiviral drugs we've got, amantadine is the oldest one. It's got a brand name which I knew yesterday. It's used for treatment of Parkinsonism a little bit. It is not a neuraminidase inhibitor. It actually acts on those M2 ion channels that I spoke about. But it's used now, previously even mainly for prophylaxis, and the strains developed resistance to it very quickly, so it wasn't used a great deal. It hardly ever gets used now for treatment of influenza because we have better drugs, and these are the neuraminidase inhibitors, which target those neuraminidase spikes on the protein and prevent it from being released from an infected cell. It's best to start these within the first 24 hours, and you probably won't even see the patient within the first 24 hours, so often we miss that opportunity, but even up to 48 hours there's definite clinical benefit. It doesn't cure it, it doesn't, it reduces symptoms, and it possibly reduces the mortality rate, but there's a lot of conflicting data about these drugs, and it's partly fed by the fact that when Roche was developing the first one, which was Tamiflu, oseltamivir, they didn't release much of their data for scrutiny. So there's just been so much attempt to pull this drug down or to promote it, and not a lot of really good informed information, debate about it. But it does seem to have some benefit if it's started even later in people who are really sick. It's an oral drug. It's mostly has been studied in healthy adults, as most drugs are. And it only shortens symptom duration by about a day, but it does reduce symptoms. And there hasn't actually been a study in children, which is the biggest problem, but it doesn't show great beneficial effects except in immunocompromised children. The second neuraminidase inhibitor that you'll be familiar with is Influenza or zanamivir. This is an inhaled drug. There is an intravenous formulation which is not fully registered in Australia, but can be obtained on special access schemes, and it has similar clinical benefit to oseltamivir. Oseltamivir causes gastrointestinal side effects in quite a significant number of people who take it, so possibly Influenza is a bit better for people who get those side effects, but it's also suggested that it might be difficult to use in people who have asthma, and also just the technique of inhaling it sometimes is a problem if people are very ill. There is a third drug called peramivir or ravipab, which is a single-dose intravenous drug which has similar efficacy to Tamiflu, and it's more expensive, of course, because it's much more convenient, and it's newer. Not widely used. A fourth drug, lenanemavir or Inavir, which isn't registered in Australia yet, which is why the product has got Japanese writing on it, because it was developed there and it's marketed there. It's an inhaled drug, and it's got similar efficacy to oseltamivir and zanamivir, but it's got a benefit of being really strongly binding to cells in the alveoli of the lungs, which is where you've got virus replicating. So it could potentially be a better drug, but we don't have it here yet, so we don't know. Antiviral drugs are also used for prevention, especially the neuraminidase inhibitors now. Amantadine isn't used very much anymore, as I said. Those three are all approved in Australia for prophylaxis of influenza. They do significantly reduce the risk of symptomatic influenza, and they should be considered for high-risk contacts of a confirmed case, and especially those with high risk of complications or people who are not vaccinated or who you expect not to have any immunity. But they're not an alternative to vaccination. So if you've got a case in a household, it's recommended that every other person in the household where there is a high-risk person gets treated with oseltamivir as prophylaxis. That's everybody in the house. So you'd think about that for perhaps houses where there's a child on chemotherapy who you know is going to be very susceptible. You might think of it if there's an elderly person in the household. Would you think about a young otherwise healthy person with asthma? And would you think about using it where there's a pregnant woman in the household? These would all be recommended situations where everyone gets it. They're also recommended for residents in aged care facilities or residential care facilities, in addition to infection control measures, which are really far more important. That has to be done in collaboration with treating GPs, and as you know, these drugs aren't on the PBS, so there's a cost to every resident, and in most facilities there'll be a number of GPs looking after the patient, so it's really difficult to get one to get everybody to be prescribed oseltamivir to prevent influenza in an outbreak situation. And we have talked about trying to get standing drug orders or something so that if there is an outbreak in an aged care facility, it doesn't depend on everybody getting their own GP to prescribe it, but we haven't been able to get very far with that. It has to be started within 24 hours of declaring an outbreak, and that's equally difficult. And it's recommended for all asymptomatic residents, regardless of whether they've been vaccinated, and for unvaccinated staff. And there really shouldn't be any of those, but we just cannot get that made mandatory for staff in residential care facilities. And has to continue for 10 days or until the outbreak's over, whichever's longer. But then the problem is another case, another outbreak. Do you do it all over again? Do you do it all over again? It's not ideal. Infection control is really the answer, and vaccination. It's very effective in inpatient settings, so when we've had flu cases in cancer wards, everybody goes on Tamiflu, and it saves lives there for sure. Public health management, the most important thing, of course, is vaccination. I'm not going to talk about that because Noel will talk about that far better than me. But it's the most effective prevention, even though we know it's not perfect. And in residential cares, we need all staff and all residents. Now we have a situation now where we require all our state hospital nurses to be vaccinated against flu. We wish that would become the situation everywhere. Testing is very important. So we need it for surveillance. We need to know what the numbers are. Not just the case numbers, we also need to know what subtype we've got. We need to know what subtypes are circulating to inform vaccine development, to inform us about whether the circulating strains are a good match with the vaccine. If they're not a good match, then there may be different advice going out about how to manage people or the situation, and it alerts us to the emergence of new strains, so it alerts us to a new pandemic strain. And the third public health measure, of course, is antiviral drugs for treatment and prophylaxis. Pandemic influenza, of course, gets our priority response for public health management, just the way coronavirus is taking us away at the moment. But seasonal influenza is, we do have a lot of involvement in managing that. We don't get involved very much with individual cases, but we do get involved in promoting vaccination, education, awareness raising, promoting personal hygiene, which is very important, and our most important public health action as a CDCB is involved in providing help to residential care facilities when they have outbreaks. So we have hundreds of outbreaks reported in some years, which keeps us very busy. We try to raise capacity within that sector about an infection control, about the use of antivirals. We do some training in epidemiology so people can do things like line lists and work out when outbreaks are over and where they need to focus their attention. This is just the table I showed you before of the number of cases in South Australia, and the red numbers are the number of outbreaks we had reported in those years. So it does roughly correspond with the number of cases as you'd expect. But last year we had 107 outbreaks in aged care facilities that we were trying to assist with, which was very time consuming for us. And I looked at the names of the residential care facilities where the outbreaks were, thinking maybe there were some really bad places that we might be able to focus on. But in fact, there were very few repeat offenders. Most of the outbreaks were in one place and they didn't have another outbreak, or they didn't tell us if they did have another one. The infection control capacity in aged care facilities is improving, and their ability to manage these situations is certainly improving. This has been helped by a CDNA document about just guidelines for management of influenza outbreaks in residential care facilities, which is at that website down there, but you can just search it under CDNA guidelines influenza and you'll find it. And I think that Lisa's going to speak some more about this document, but just it's got a lot of useful information in there. So it's got sections on about just the basic influenza stuff. It's also got a lot of advice about managing outbreaks, vaccination programs and infection control, and a lot of signage that's useful for facilities if they have a case. I couldn't find a picture of a lockdown thing, but I know that sometimes it gets to that sort of situation. And that's my talk, and does anybody have any questions for me?
Okay, thank you very much, Anne, for that detailed insight into the influenza virus, our understanding of the virus and how we apply that to the clinical public health aspects of the management of the virus. So Jeff is going to take the microphone now, and if anybody wants to ask a question, if you could just put your hand up and use the microphone.
The infectious disease guidelines for nursing homes, I think, includes point-of-care testing as one of the recommendations. So have you got any comments about point-of-care testing? Is the department looking at increasing it? Because that point-of-care testing is obviously better than it was. And there's some recent study in Western Sydney showing it's been able to reduce the length of an outbreak in a nursing home from about 20 days down to 17.
Yeah, thanks for
early introduction point-of-care testing.
Yeah, thanks for raising that. That's a really good question, and I'm not sure how much point-of-care testing is being done in residential care facilities in South Australia, but it would be very useful. The tests are getting better, as Rod said, and they have got a good positive predictive value. So if you get a positive, it's a positive. If it's a negative, it's not necessarily a negative. So in South Australia, we have point-of-care tests in some of our emergency departments during the flu season. At the moment, we are retesting all those samples in the laboratory, but I think if point-of-care tests get good enough and cheap enough, that should actually be built into the CDNA guidelines about managing influenza outbreaks in residential care, and it's, when the document's revised, I'm sure that'll be included. Because it does allow you to test early. You don't have to wait usually a day or so to get a result back, and remember you've only got that one day when the antivirals are so effective to get them started. So thank you, good point. Thank you very much.